Hello, this is Dr. Ayub. So I'm going to do the continuation of the GYN anatomy, that is female reproductive system anatomy, and right now I will cover up the uterine wall and vasculature of the GYN, that is arterial supply, venous drainage, and also the lymphatic drainage too. Then I will try to get some physiology, and I will try to discuss about the menstrual cycle and the ovarian cycle. Uterine wall has a tremendous impact in the clinical settings, because the three layers in the wall have the three different types of disease process, and those are the main area of the uterine pathology. Okay. The uterine wall has the outer layer. Outermost layer is a perimetrium, and the middle layer is a myometrium, and the innermost layer is the endometrium. The perimetrium, it is actually the visceral peritoneum and the perimetrium, they fuse together and up to the isthmus level. Okay, the whole uterus is not covered by the visceral peritoneum, and perimetrium is the outer layer of the uterus, and it is its own layer, perimetrium. But this perimetrium is continuous or fused with the visceral peritoneum up to the isthmus, and after the isthmus is reflected back onto the rectum. That's why when the surgeon do the surgery for the C-section, they make the line of incision and below the perimetrium, below the visceral peritoneal layer, because they don't want to interfere the peritoneal cavity, because if any infection happens, it can easily spread into the peritoneal cavity. That's why they don't interfere the peritoneum. Okay, this peritoneum for perimetrium, for ultrasound purposes, this is hyperechoic. This is hyperechoic, and it is the outermost layer, and firmly attached with the myometrium. Firmly attached with the myometrium, and it may have some disease. They might be involved in the PID, okay, pelvic inflammatory disease, PID. Also perimetritis separately, Also, it may show the endometriosis. That's why we should not ignore the perimetrium, and it helps us to put the measuring caliper to measure the uterine height, width, and length. Okay, so you can write down. It helps us to put the measuring calipers onto the uterus for length, height, and width. Okay, so this is perimetrium. Now the myometrium. Myometrium is very important. It is the muscle layer. Okay, it's a smooth muscle, and this smooth muscle is very tight muscle. Okay, it has a different directional muscle fiber, makes is very tight and thickest layer. It's a muscle layer, middle layer, and the thickest. And it gives the view is a homogeneous and medium level hypoechoic. Medium level hypoechoic, and it is really very vascular. Very vascular, and it gets more vascular when there is pregnancy, during the pregnancy. Okay, and at the third trimester, the thickness of the myometrium is thinner. It will go up to the 5 millimeter. Okay, so that's why if there is a pathology in the wall, or due to cesarean section or some trauma, the myometrium in third trimester pregnancy can be ruptured too. Okay, so it is highly vascular, and it may develop, may have both benign and malignant diseases. For the benign, most common is fibroid, leiomyoma. Okay, so fibroid is very common in the uterus, very common. Some fibroid needs treatment, some fibroid may not need any treatment, just observe and follow up. It may go away spontaneously after menopause. Okay, so that's why some fibroid will remain as it is, and also depends on the location or the sites of the fibroid. Where is it? As long as the fibroid is small and is far away from the internal os, then it's fine. Okay? You can keep it. And the malignant leiomyosarcoma can develop in the myometrium. And also there is a disease called adenomyomatosis. That means the endometrium may extend into the myometrium. That time you can see the myometrium is a different appearance, and sometimes the myometrium gets weaker. Okay, so very rarely the myometrium may develop a cystic appearance. Usually it is due to necrosis because of some benign tumor compromise with the vascular supply. The cell death happens and you might see necrosis, or due to some trauma there might be some fluid collections. Okay, and now endometrium. Let's talk about the endometrium. Endometrium is the innermost layer. It is the innermost layer, and it is hyperechoic. Than the myometrium. It is hyperechoic than the myometrium, and its cellular type is a glandular cells. It's a different types of cells than the myometrium. Myometrium is a muscle cell, but these are not muscle cells. These are the cells that has apoptosis, means programmed cell death. By every month it changes in thickness and they shed it out during the menstrual cycle. And this endometrium has functionally there are two types of layers or two zones. Okay, it has two zones. One is tunica basalis, and another is tunica functionalis. Tunica basalis is the mother cells or base cell. Mother cells, they produce the new tunica functionalis cells or during the every cycle period for a month. Tunica functionalis is the shedded out. Every cycle, shed it out during the period, okay? And the thickness varies according to the phase of period. That is the menstrual period, according to the phase of the menstrual period. Okay, so this endometrium gets highly vascular, okay, when it is active. and when it is avascular, so you are not going to see the vascular activity. That's why we need to understand that sometimes we need to click the color onto the endometrium to see the vascularity. Sometimes there is a written product of placenta. That placental tissue and the endometrial tissue, they appear the same brightness. So if you click the color, you can see the vascular activities. Then you can feel like, oh, these are the active cells. Okay? So if it is a written product of placenta, so and it is vascular, so that is bleeding, right? That bleeds. So that need to be cleaned out. Okay, so we need to understand. The normal thickness of the endometrium varies, that I said. During the ovulation time, it is usually 1 centimeter or 10 millimeter. But I found cases during the period, during the ovulation time, 1.2, 1.3, even 1.4 centimeter with the triple line. Yes, I saw it. Okay, when you see the triple line, means in the center echogenic and by the side there are 2 walls. You can see echogenic and it looks like a tri-stripe. Okay, so you measure at the time, you might see 1.4 centimeter too. And this is normal. If patient has no complaint, you have to take the history properly. Ma'am, are you having any ovulation soon? Or ask, when was your last period, first day of last period? Then you can easily calculate. You can easily calculate the ovulation time and the thickness. More thickness you see during the secretory phase. Okay, secretory phase, you know, the last 2 weeks. Okay, so these are the 3 layers you need to remember, and you know that most of the time we measure the endometrium in its thickness. Okay, it is a protocol image. Okay, and for the uterus, in the protocol we will discuss that what are the things from the uterus we measure and what we look for that. Okay, so now I will go over the vasculature of the uterus. Uterine arterial supply. Okay, so if we understand that this is the aorta, the distal part and the bifurcation of the aorta, okay, this is aorta. These are common iliac arteries, and this is internal iliac artery, and this is external iliac artery. Okay. The internal iliac artery, it gives the blood supply to the pelvic cavity, and the pelvic cavity has muscles, bones, and the reproductive organs and the bladder. All those structures are getting blood supply by the internal iliac artery. The other name of internal iliac artery is hypogastric artery. Hypogastric artery. Okay. So now the uterine artery is a branch from the internal iliac artery. Okay. So now if I give the command of the supply, so aorta to common iliac artery, I am using the abbreviation, okay, the shorthand, common iliac artery to the internal iliac artery, internal iliac artery to the uterine artery, uterine artery, and the uterine artery gives rise the arcuate artery, from the arcuate artery it gives the radial artery, okay. From the radial artery it gives the spiral arteriole, spiral artery, and it forms the arterioles, okay. So now let's see who is where. This uterine artery, internal iliac artery is in the pelvis. This uterine artery has extrauterine and intrauterine under the perimetrium. Under the perimetrium, this uterine artery. And keep that in mind, there are two uterine arteries. This arcuate artery is under the perimetrium in an arc, ARC, in an arc form, means the curved. Radial artery passes through, travels through the myometrium, travels through the myometrium vertical to the endometrium. To the endometrium. Okay, I will draw the diagram, and at the tip of the radial artery the spiral arterioles form. Okay, this spiral arteriole is mostly, it is in the endometrium. Mostly it is in the endometrium. Okay, and this arterial circulations is very important. Internal iliac artery we can see, Uterine artery, extrauterine we can see, and intrauterine under the perimetrium we can see. This artery can be tortuous, dilated, and extrauterine part can compress the ureter on the right side. Those who are multi-gravid and having uterine artery dilated tortuous, it can compress the ureter that is posterior to it, and it can cause hydronephrosis on the right side. And the tortuous intrauterine part that is under the perimetrium, we can see the tortuous and dilated anechoic tubes in sagittal view and also transverse view of the uterus. Sometimes it could be confused as it is an ovary. When you don't get the ovary anywhere, you feel like this is an ovary because the anechoic dot, anechoic things, you feel like these are the follicles. Then click the color, then you see it is a colorful, so it is not the ovary. Okay? So we can see the uterine artery and we can do the Doppler. We can do the Doppler study. We can take the peak systolic velocity and end diastolic velocity. So sometimes we need to evaluate this artery to understand the resistance of the flow. If there is a mass inside the uterus, if there is some death of the tissues, dryness of the tissues, distal tissue, so artery will face a lot of resistance, especially during non-pregnant uterus. They are resistive artery. But when the uterus gets pregnancy, gravid uterus, its resistance is less. That's why you see the peak systolic and end diastolic is different. Okay, is different. And also in during the menstrual cycle, you will see the resistance is different too. Phase to phase, they are different. Okay, so now arcuate artery we can see just under the perimetrium, and it goes around the uterus. It goes around the uterus and make an arc on right side and on the left side. With good transducer, better resolution, we can see. Even though we can see the radial artery, that is, it runs perpendicularly. It runs perpendicular onto the endometrium from the arcuate. That's why its name is radial, because its distribution is just like as if it is taking the measurement of the radius of the uterus. And you know the radius is the half of the diameter, right? For in one side, the radial artery, it looks like it's taking measurement of the radius of the uterus. And there's a multiple radial artery pointing towards the endometrium. And the spiral artery is a spirally arranged. Okay? So now I will draw the diagram of the vascular system. You have to understand that